Starts on the lower or the middle lateral external border of the scapula, as you can see in the picture, and it goes over to, what is that? Where is it attaching on the humerus, Teres Minor?
Greater tuberosity.
Oh, you know that now. Everybody knows that
It's
now.
there.
It doesn't say greater tuberosity there, it just shows an attachment site. That could be anywhere. Okay, so greater tuberosity. So what are the three muscles that attach to the greater tuberosity? The three rotator cuff muscles?
Supraspinatus, infraspinatus, and teres minor.
Teres Minor, the one we're talking about now. All right, three of the rotator cuff muscles, three of the four rotator cuff muscles. Why are they called rotator cuff muscles?
Because they rotates the shoulder.
Because they what?
They rotates and stabilize the shoulder.
Rotate and stabilize the shoulder. That's exactly right. How do they stabilize the shoulder?
By contracting all together.
By the very nature of what?
It's a synergist action. They contract together to stabilize the shoulder.
The reason that it's called a cuff is that they form part of the kind of suction cup aspect of the glenoid. The kind of, it's a ball and socket joint, right? But the humerus is hanging in space, so it needs something to kind of stabilize it. So those three muscles attach into, side by side, beside each other, into form a cuff along with the subscapularis that helps create a suction effect on the head of the humerus, holding it into the glenoid cavity. So they're called the rotator cuff muscles. All right, great. So what does that to Teres Minor do? Is it one of these muscles?
Externally rotate.
Oh, it externally rotates, so it's one of these muscles. So what?
C6.
Oh, you're a neurologist
C6.
already.
C5.
C5, Teres Minor. Oh yeah, no problem. We know this stuff. Okay, great. So how are we going to test this now? What's the difference on Teres Minor and infraspinatus is kind of the angle, right? The angle. So, do you want to volunteer? Phyllis? Okay. Red, blue, and draw. Okay, good. Hang on.
I had to come all the way from Brunswick to get a good marker here.
Okay, we're ready. Yeah.
No good markers in Quebec.
Well,
I'm bringing in from other province.
but there's a lot of people in New Brunswick that speak French.
Wait.
It's almost part of Quebec then, sort of. Okay, so what we're going to do is we're going to go from that lateral border, and we're going to go up on more of an angle, right? That's actually not quite right. I'm a little bit high here. It's more like this. Sorry about that. Okay. But this, as opposed to this, you see this isn't more of an angle. So we just follow this angle. So this line, and if this is at 90 degrees, and the forearm are on the same line. Okay, so the movement of this Teres Minor is just relaxing. One fist length away from the body, and just relax, a 90-degree angle here. So that's the movement. The difference is infraspinatus is up here at 90 degrees. That's the movement. This one we drop down, and that's now the movement. See? Go ahead and move it. That's lengthen, that's shorten. Lengthen, shorten. Okay? All right. test the strength then is just simply having a shortened position. Is this the shortened or lengthened position?
Short.
Lengthen. Sorry, it's internally rotated, right? Okay.
Which one is it, lengthened or shortened?
Okay, that's shortened. Okay, no,
Okay.
shortened.
So is that the start position for the length test then?
No,
What is it the start position for?
internally rotated.
For the
No, what is this the start position for?
strength.
Length or strength test?
Strength test.
Strength.
Strength test, okay. All right, so that's the, okay, so let's do that strength test then. I'll put my hip here, I'll put my leg there, and just hold it as hard as you can, and I'm trying to push it, relax it. So I'm 90 degrees, see how I'm 90 degrees still? 90 degrees, and trying to push that in, okay? All right, good. I can hold it here as well, okay, here we go. Hold it there hard. Now I'm trying to do it. See, I'm 90 degrees perpendicular to the appendage in the direction of the line of the movement dynamics of the muscle. Okay? All right, great. So that was the strength test. Trying to push it in. Hold it. He's trying to push it out. It's an external rotator. He's trying to hold an external rotation. That's the strength test. Where would the length test be? So we'll go opposite to that. Come through both sides. Relax. And I'll just try and pull it a little bit out from his body here. See which side is pulling in more. If one is like that and one's like this, then the left one would be short. If it was like this, then the right one would be short. But in his case, they're even. So that's pretty straightforward. Great. So the strengthening procedure, all right, is exactly the same as the infraspinatus. Very simple, but we're just on a different angle.
Yeah.
So now this stuff's pretty easy. Breathing shouldn't take too long, and go slowly. Breathing, and go. So this is easy. Now we pretty much have this. You can figure this out. Length test. Okay, we're going to, you can do it this way, or you can do it this way, whichever way you feel is easier. I kind of like this. Breathing. And what he's trying to do now is he's just pressing against himself here, trying to do that. Breathing, and go, and I'm preventing it. And relax it, and I'm pushing it out a little bit. Feeling where it's contracting, breathing. There it's contracting there, I can feel it. Relax, exactly where I marked it, breathing, and go. And relax it. And that's your teres minor length, TL. Yeah, so that's pretty straightforward, eh? We're all getting a little tired, eh? I can see, I know too, I know.
What was the
It's a lot of
strength
stuff.
test?
What was the strength test?
Yeah.
I don't know, you tell me.
It would have been if your arm was up.
And he holds it in this position, and he's trying to, he's got the muscle contracted, so he doesn't want to move it, and I'm gonna try to push it into the opposite movement, internal rotation. He's gonna hold it, which means he's contracting the muscle, testing the strength of the muscle, because it's in a shortened position. Hold it here, and he's testing it now. I'm pushing, relax it. I'm trying to push it into internal rotation. I'm trying to break the hold of the muscle, which is contracted in external rotation. Right? Any other questions about it? Any other questions? No? You guys are dying on me, all right? We're dying, are we?
Yeah, I have a question.
Yeah.
A while ago, you treated his frozen shoulder with impingement syndrome. If you have adhesive capsulitis,
Oh, by the way,
does
we
it
want
work?
to see if that was sustainable. Can we see if that was sustainable? Go ahead. So far, so good. We'll have to see tomorrow morning. I don't know if it's going to make it through the night or not. Okay. Yeah.
Yeah. With frozen shoulder, adhesive capsulitis,
Yeah.
can we do the same, or
You
a
can-
different sequence, like
With frozen shoulder adhesive capsulitis, you're able to address the muscular component. When you address the muscular component, which is applying the secret, what do they call it? The secret formula? What do I call it? The secret formula? The secret formula? Trigens formula?
Yes.
TL for the big three. When you apply those big three, you'll be doing the same thing I do before I actually do the operation, the OAT operation, and that will address the muscular component. There's a muscular component and a capsular component. A muscular component, when you address it and you do the big three, TL on latissimus dorsi, TS on deltoid, and TS on supraspinatus, those big three that I told you about, you will get an immediate, doing nothing else, you will get an immediate increase in abduction, usually anywhere between 10 to 20%, but sometimes I've seen it as much as 10 to 20 degrees, and sometimes I've seen it as much as 40 degrees, immediately, within like a couple of minutes.
Okay.
And this is after they've been going for physiotherapy for sometimes years, months, receiving chiropractic treatments and acupuncture and whatever, you name it. They've been trying everything, massage, and nobody can believe it. It's quite, it's quite unbelievable. So that you can treat, but when that's done, then, and of course you can check all the other muscles as well for imbalances and treat them also. And you will definitely help the patient more than anybody else will have helped them. That's 100% guaranteed. Guaranteed. The problem is if there's still a capsular component, which there will be if it's a true adhesive capsulitis, then the capsular component has to be, where's the camera? Video. The capsular component has to be addressed, and the only way you can fix that is with the OAT non-surgical operation that I do, and that we've trained someone in Australia, New Zealand to do as well.
Okay.
And we will be training other people to do it, but it's how many of you have seen some of that work that I do on YouTube? Anybody seen that? Yeah. And that is a multidisciplinary, integrated non-surgical operation that breaks open the capsule safely and doesn't cause any damage to the other tissue. Okay. It's the first of its kind in the world. It's the only treatment that can do this.
Okay.
And we use, there's a medical doctor that does injections. We use 4 or 5 different drugs and medications with it, so it's pretty involved. The shoulder's injected with ibuprofen, which is Marcaine, which is a long-lasting analgesic into the joint, because it's quite a painful procedure, pretty intensely painful at some point, like having a quick baby, basically. And also we use a little bit of corticosteroid, Kenalog, and then we give the patient some narcotics, oxycodone, and we also knock them out a little bit more with hypnotic sedative called triazolam, depending upon the size of the patient, the dosage that we give. And then we also do an injection intramuscularly of diclofenac we inject as well to give a whole. So it's a pretty heavy duty thing. We have to break open the capsule, we have to dissect the tissue, the capsular tissue, and to make sure we do it safely, which can't be done with a manipulation under general anesthetic, MUA. Can't be done with that. It's 80% of the MUAs are causing damage.
The doctors here are big on the cortisone injections in the capsular part of the shoulder. If one of my clients does that for the capsular part, if he comes back to see me, can I help him more?
Yeah, the problem with the cortisone is that, the cortisone is going to temporarily decrease the amount of impacted inflammation in the joint. The joint's impacted with inflammation. It's just impacted. There's so much inflammation. So it's going to artificially decrease the inflammation temporarily. but it's also going to emulsify and weaken the tendons permanently.
Okay.
So there's some emulsification and weakening of the tendons that's permanent. It's not reversible. We even do some cortisone, but we do a very small amount of cortisone just to keep the inflammation down post-operatively, right after the operations, because otherwise there might be a fair bit of inflammation. So we only use it for that, and we do a very small amount because actually, if you inject a small amount, the research studies show that it's the same as if you inject a lot. There's not much difference on the anti-inflammatory response. So there's no record or no history and no clinical evidence whatsoever that cortisone helps adhesive capsulitis in any kind of a sustainable way.
Okay.
There's some temporary. Maybe relief from pain because there's not as much inflammation, and there's maybe sometimes there's a little bit of temporary increase in mobility, a little bit maybe, but that's, if it is there, that's very temporary, and it just goes back to being the same way it was. There are definitely cases where a frozen shoulder impingement syndrome or tendinosis or tendinitis, biceps head tendinitis, supraspinatus tendinosis, all those things which they use cortisone for, but the cortisone injection has caused the adhesive capsulitis.
Oh, okay.
There's many cases like that. So cortisone injections not done correctly potentially can also cause adhesive capsulitis, as can the flu injection. You go get the injection into your shoulder. Any kind of injection into the shoulder can actually cause adhesive capsulitis. There's lots of reports and write-ups in medical journals about it. But that's another whole reason for that. So I don't know.
Yeah, that means.
I think for a lot of people here, it's probably not interesting what I'm talking about. Maybe we should talk about it afterwards. This is probably a little bit boring about this stuff. It's not what you're doing, so. But I can just tell you this: if you've got cases of adhesive capsulitis, frozen shoulder, the real adhesive capsulitis, frozen shoulder, send them to me. I will open the joint up for them, and then I'll send them back to you.
Okay.
And then you can really help them.
Okay.
Then the recovery rate, when you start working them, is just.
That means there will be, there will be an incision on the shoulder.
Be a what?
There will be an incision because you're gonna open the capsule,
We're not doing surgery. We're internally dissecting the capsule. We're using injections. We're using local anesthetic, but we're not surgically opening the shoulder.
You will just manipulate, do the.
It's kind of a combination of trigenics with a specific form of manipulation that I developed specifically for this condition. It's not like any other type of manipulation that you.
Okay, that means you're gonna identify that there is a capsular involvement after doing the PDM, let's say.
If you treat the adhesive capsulitis and you do the capsule, you do the muscular component, and there's still
limitation,
an end range, abrupt end range locking.
Okay.
In 3 ranges of motion: external rotation this way, internal rotation this way.
Yeah.
If they have adhesive capsulitis, they're usually not able to get much past here. But some of them can go to here, but it's only because they're using the scapula. They're very flexible. They're using the scapulothoracic joint. Actually, when you do the impingement test on it, it's down here.
Okay.
Okay, so when you do that test, that gives you the true range of motion. And they can't do this. So one arm will be like this, and the other arm will be like that. And they can't put their arm, behind their back, right? They can't do that. They're basically doing this. Their elbow can't even bend behind their back like this. Send them to me, and I'll fix them, and then they'll be fixed literally within a day. They'll be from here. They'll be to here in 1 day.
In 1 day.
1 day. It's never been done before. There's no one else in the world that can do it.
Okay.
How much?
How much? $7,500 US.
7,500.
About 10,000 Canadian. What? It's the cheapest game in town. We're the lowest price for any type of operation for adhesive capsulitis compared to MUA. MUA is much more expensive. Arthrocapsular release, much more expensive. Arthrodilation, much more expensive. We're the least expensive of all of them. And we get the best results.
Can that be shouldered by insurance, private insurance?
Yeah, it's covered by insurance in the United States. Lots of the Americans have coverage for it.
About here.
Well, I don't know about here. Here is more difficult because, yeah, but the Americans, we get mostly American, we get a lot more Americans than Canadians, and most of them have coverage. Yeah, the Americans have coverage, yeah. So maybe some of the Canadian companies do too. I'm not involved in the insurance side of it. Valeria, are you around? Is there insurance coverage in Canada for the OAT? Or is it mainly Americans?
What is it, sorry?
Is the insurance coverage only mainly for Americans, or are there some Canadians getting covered as well?
The Canadians, they cover partial, they cover the initial assessment.
No, for the OAT.
No, they cover the assessment.
Well, the assessment's only $300.
No, it's $500.
Oh, $500.
They cover $500, but in the United States, they cover 80%.
So in the United States, they cover 80%, right? So the
Depends on
Canadian
insurance,
companies are
right?
not covering that
But
much.
the
Okay.
majority of insurance companies, they start to cover the whole
Yeah,
non-surgical operation. Yeah.
it's pretty intense.
But that's
We have
what we are seeing.
We have a team of 4 therapists assisting me. So there's like the whole table is covered with people.
But the frozen shoulder is the advance of the trigeminus. To get to the frozen shoulder, to do the non-surgical operation, you have to get through to each course, and you have to have a knowledge of all the trigenics protocols, right? Because
Anyway, so let's continue then. Let's do, any other questions? Anything else you want to ask about while we're just hanging around and not feeling like doing too much?
Yeah.
You have all these questions. Are these questions interesting to you guys? I don't know.
the trigenics
What is the question? Valeria?
any condition of the shoulder.
Yeah? What's the
Yeah,
question?
because I don't know. Way back in the Philippines, I've been doing this, as I said. We have a patient with a frozen shoulder, but it takes a long time for her to get the range of motion. Like I did it 20 sessions for her to be able to get that one.
Yeah, the non-surgical
Well, that's
operation,
good.
like Dr. Austin does,
Okay.
he fixed the shoulder in 2 visits.
Just in 2 weeks.
one visit.
In
huh?
one visit,
Just one
the
visit,
second visit
okay.
is a follow-up.
Okay.
Okay. No other questions? Let's get to it. I think we're getting, maybe we break, should we make